All right, I'll let you take it away.
Thank you, Amy, so much. I appreciate this. And how this all came about is Amy contacted the Minnesota Network of Hospice and Palliative Care. And through that, I got linked with all of you. So I count it a real privilege to be with you today. We're having a little construction going on in my house, and Amy told me that you can't really hear it. So I'm really thankful because I've moved to the lower level. But we're having some carpet lifted after way too many years. And I'm so excited, but I'm just sorry it's on the same day that I'm meeting with all of you. But like I said, this whole Zoom experience, I think we've all learned to extend grace, haven't we? People have seen the inside of our houses and our cars, Sue, and, and whatever it might be, you know, that we would have never sort of like shown people before. And so it's just, I think it's the silver lining of the pandemic is something that I try to concentrate on. And thank you for that nice introduction, Amy. I just wanted to state that you will be receiving a copy of the PowerPoint and the handout after today's session. So you can just sit back and relax and not even have to take many notes, if any at all. But I just wanted to point out, as Amy's already stated, the CHPN behind my name does not mean I'm a chaplain. It is a certification in hospice and palliative care. So I just wanted to state that. I have my own independent consulting business. I've been in this for 17 years. Prior to that, I was a founder and director of a Medicare certified hospice program and home care in Litchfield, Minnesota. So greater Minnesota is my deal. And just to let you know, when I live in Rochester currently, but whenever people talk about outstate Minnesota, I gently correct them. We're not out of the state, we're in the state. And so I say, we're greater Minnesota. What do you guys all think? Right? We are not outstate, just about, it's one of my pet peeves. And so I will keep championing that cause. But what I'm using today, I traveled around the state, a couple of years ago, through a grant that our state organization had along with Stratus Health. And we really tried to do some training and teaching on many different subjects, one of them being palliative versus hospice care, what's a healthcare directive, what's a POLST, etc. So I am using some of the same learning objectives in the slides we used as we traveled around the state for MNHPC. Now, this might be a little bit hard to understand, but I just wanted to put it in here in the standpoint of, we know that all of us on this call are on a trajectory of quality of life. And I have to tell you that somebody has been sneaking into my house. And guess what they've been doing? They've been flipping my calendar on me. And I keep trying to wake up and find out who that elf is, because the time just goes so quickly. I've been a nurse for 46 years, and I can't even believe it myself. But this trajectory, what the encouragement is that we start the conversations about serious illness early in life, so that we even know what an adult at age 18 would want in the event they could not express it for themselves. And then we move on this line, this arrow that I'm pointing out here. You know, suddenly there can become a diagnosis of a serious illness. And this is where we're going to discuss palliative care, because it's not a terminal illness, but what is a serious illness? And I could spend more time talking about that, because I think as providers, we sometimes need to tell our clients what a serious oops, I just scooted here. What a serious illness, my pointer is really quick here. What a serious illness is. Is it a serious illness to have a thyroid, hypothyroidism? No, it's treatable. Is a serious illness Alzheimer's? Is a serious illness insulin-dependent diabetes for a juvenile? Yeah, that's pretty serious. So what is this trajectory? And then we talk about end of life. And then I'll end my conversation today talking about hospice in comparison to palliative care. Well, palliative care, I've heard people say palliative care, but actually nationally it's pronounced palliative, palliative. So here is even just a, if you will, a descriptive on how to pronounce it. I remember my father asking me at about 88 or 89, Loris, you've been doing this consulting for 17 years, but what do you really do? Have you ever had your parents ask you that, or your kids? What is it that you really do? And I find myself going into way too much detail. But he said, what is this thing that starts with P? What is that? I think it is a mouthful. But if we look back at the definition, palliate, means to cover or a cloak around somebody. And that's really what I'd like you to remember today. It's really coming around somebody with a serious illness. I didn't say terminal, a serious illness with specialties to say, what is it that's important to you? What are your preferences now that you know you have a serious illness? And I don't even use the word goals of care because I don't believe that resonates with laypersons. What are your goals of care, Amy? Well, I don't know. Maybe cure. But if I ask you the question, what is your preference now that you know this diagnosis? You may say, I want to be kept comfortable. I want my symptoms addressed. I'd like the least amount of nausea as possible. I would like as much energy as potentially possible. I would like to know that I'm safe. I want to know that my young children are not ignored during these discussions. And that can lead to another whole discussion. So that's really, and I'll have a little video to show you that might better explain palliative care. I've had people ask, well, where do I get it? Where do I ask for it? And so I think that's something to come back to the AAAs to ask yourself, what kind of resources do you have when people say, does this hospital provide a palliative care team? Is that available through hospice? Is it available through home care? Is it available through a clinic? And as we see nationally, the uprising or the outcropping, whatever you want to call it, of palliative care often started with hospitals. Hospitals would say, you know what, we have a palliative care team because we're seeing that, I'll use myself, Laura's is being readmitted frequently for her congestive heart failure. What could we do better? Has anybody stopped to visit with Loris to ask her what kind of support she has at home or not at home? And what is her preference? Does she want to be in intensive care? Does she not? And so hospitals were able to say, if we create palliative care teams as consult teams, you know what? It's going to save us money. So they were able to do some cost shifting without direct reimbursement, perhaps from Medicare. So we have challenges, and I could go on and on about who pays for what, because that is something that we always think about. So the National Consensus Project, and there are many different folks who have weighed in on this definition of palliative care. The World Health Organization, CMS, Medicare and Medicaid, also the Center to Advance Palliative Care. But here's a definition that I appreciate as one of many. Palliative care really focuses on expert assessment and management of pain, but it doesn't stop there. Because if that's all we did, we would not need a social worker, chaplain, pharmacist. We could just really depend on physicians and physician extenders and nurses. But palliative care is very similar to hospice in the fact that it attends to the physical, functional, psychological, practical, and spiritual consequences of a serious illness. I really like this word practical. Now that I have a serious illness, I can no longer work. Well, the practical issues are this. I was the main breadwinner. Now what? So I think that palliative care approach is paying attention to more than just, as I said before, the physical. It's also paying attention to the family. What does this mean for the family? I had a young patient that eventually enrolled in her hospice program. But first of all, she was in home care. And one of her greatest concerns was that of her 3 young children. Her husband had to quit his job to care for her. She had advanced ovarian cancer. Her medications were costing somewhere in the neighborhood of $3,000 a month. And that was nearly 15 years ago. And she said at one point, I would be better off dead than alive for this family. All I'm doing is costing money. And as we know, a family medical leave does not put bread and butter on the table. It just gives you a leave from your job. And so her deep emotional concerns about not only her illness, but as she saw it impacting her entire family, that would be a really awesome reason to make a referral for palliative care. She wasn't yet in hospice. And we know that in home care, in our clinic settings, we become so fragmented and so busy that we don't stop and really say, now, how are the kids doing? What do they need to know about mom? What what fears do they have as they watch their mom decline? So palliative care is really ideally early integration into the care plan for seriously ill. I hope before I die or retire, whichever comes first, that clinics would have the opportunity to make a palliative care consult. Because why? I'm talking about early diagnosis. So if the early diagnosis is within a clinic setting, wouldn't it be cool to say, I'd like to make a palliative care consult? And surrounding that person would be a social worker, a chaplain, a physician, a pharmacist, and a nurse. And maybe it's a one-time visit, maybe it's multiple visits, but wouldn't that be cool instead of waiting until there's a crisis? And then we go, okay, now what? Now what do we do? So if you want to turn up your computers, and Sue, I don't know how this will work for you on your cell phone or other persons on their cell, but I'm going to play a short video. It's no more than 3 minutes, and I hope you'll be able to hear it. And it's a depiction with a narrative on what palliative care is and kind of comparing it as a bridge.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy and be sure to consider the enormous potential of palliative care.
So maybe that gives just a little bit of reinforcement to what I've already shared. So I might just ask you to think about questions. There is going to be a pause after this palliative care session, and I'll ask you to unmute your mic if you choose or type into the chat. Have you experienced palliative care? Have you asked for it? Has anybody in your family had a palliative care consult? I'd like you just to share briefly to the level of your comfort, if in fact you've had that experience. So what are some of the benefits? Already mentioned, relief of pain and uncomfortable symptoms. And I think one of the greatest joys of palliative care is somebody stopped, hit the pause button, and asked the question. I think sometimes in our medical model, we're so quick to intervene, to start this, to start that, to do this, to do that. And certainly people are not making always even informed decisions because we're so quick to offer a treatment and a new, if you will, intervention. And without stopping to ask ourselves the question, does mom know what a feeding tube entails? Does she know the risk and the burden of a feeding tube? Does she know that when it falls out, she'll have to go back to the hospital to have it reinserted? And so I think palliative care, I'd like to just say, and these are just my words, it's kind of the pause button to say, let's stop and ask the question, what are the preferences of the individual and of their family? And also it might be a real assist to help in making medical decisions, to help develop a healthcare directive. And what about navigating our complex system? Oh my goodness. We keep talking about silos and complex systems. I've heard that now for 40 years. I'm hoping the next generation is going to bring some enlightenment as they work through the craziness that we've lived through. So some other benefits are this, communication between family and healthcare persons. Now, also, what about between family members? Now, I'm sure up in the dancing sky, AAA geographic area, you never have conflicts between family members, Amy says no, between their healthcare providers. And we also know even nationally, studies have shown physicians sitting on one side of the desk think this: if my patient really wanted to know how ill they are, they would ask. The patient on the other side of the desk is thinking, if my physician really felt this was serious, he or she would tell me. And so therefore we dance around the elephant in the room and nobody knows. And then we say they're living in denial. Well, maybe they've never been told. Maybe they've never heard. And so again, just palliative care. Also, the emotional and spiritual support. Think about if you've ever had a new diagnosis that's serious or somebody in your family. It wouldn't be unusual for you to wake up at night at 2 a.m, get on your computer, Google Dr. Google, and ask yourself, how serious is this illness? Does it mean I'm going to die? What's going to happen to my family? What about my finances? So the emotional and physical support is something also not only assessed, but hopefully met. So who's on the team? Well, doesn't this look a lot like hospice? It does. It's the patient and the family who are first, a physician. And when I say physician, that could be nurse practitioner or physician's assistant. The nurse, the social worker, chaplain, counselor, a pharmacist, because the pharmacist might look at all the prescriptions mother is on with a serious illness and diagnosis and say, could we do some deprescribing? Is it really necessary for her to be on fish oil and magnesium and whatever else? Maybe not so much anymore. Or what about the cost? Could we substitute a medication that wouldn't be quite as expensive? Sometimes a dietitian is helpful. And when I talk about the team members, I am not suggesting that at all times for all things, for all patients, do all of these people come forth. But it truly is an essence of a specialty team, including perhaps a dietitian, volunteers, even bereavement support, and then physical therapy, occupational, speech, music, massage, and other therapies. So what we've learned in hospice is that coming around beside people and alongside, they report back as support they've never had in just the typical medical model. So you might think about what might that look like in our community. So I've already mentioned the models of palliative care. They can exist in hospitals. And we can go to a website through the Center to Advance Palliative Care. And we see Minnesota is actually on A through F. We have a B in Minnesota. meaning we have a fair number of persons that participate and register and fill out the surveys. And most of our palliative care teams exist in hospitals. Hospice always includes palliative care, but as you'll learn in just a moment, the specifics of hospice, as you know, is that person who has a serious illness, but then also is terminally ill. Palliative care isn't about a terminal illness. There is no prognosis that exempts or diagnosis that exempts somebody from being in palliative care, nor do they need to cease treatment, if you will. Now, I've had people say to me, I don't want to be in that palliative care program. People die in it. I don't want hospice. People die in hospice. True. Programs don't cause death, however. Diseases do. And so sometimes I've even said that, that programs don't cause death, diseases do. And yes, people do die in palliative care. And sometimes they've asked for palliative care in the last 3 days of life, or not at all. Home health can provide palliative care. One of the difficulties I'm going to tell you with home health is funding. And unless you have specific questions, I won't go into that. But typically home health under the Medicare benefit, they don't pay for chaplain services. They might pay for very minimal social services. And as you know, the beneficiary needs to have a skilled need or be homebound. And so therefore that leaves a big gap in services. But we do have some home health agencies that have said, tough, I'm going to face it head on, and we're going to figure out how to make it happen. And we're not going to allow people to be discharged from home health and then sort of hanging in the gaps. Maybe it's fundraising, maybe it's grants, maybe it's some health plans are starting to pay for palliative care. Outpatient palliative care, it seems to be not often offered very frequently. I know down here in Rochester, both Mayo Clinic and our Olmsted Medical Center have palliative care programs, but they have restrictions. You have to be at the Mayo system, you need to be hospitalized first, and then you may be eligible for palliative care to follow you once you're back home. So, and with Olmsted Medical Center, as just an example, they offer palliative care, but only within their hospital walls. They don't do palliative care consults out in the community or in the clinic. So even if insurance does pay, we kind of have to look at the availability in each community. Long-term care facilities. I worked with Serval, who wanted to develop a palliative care program. They developed some excellent work, but then the persons who were passionate about it left. And so the program just kind of was left on the bookshelf also. So whether it's a consultative team or whether it happens to be, an ongoing palliative care consult, a team that comes around somebody, it can be structured in many different ways. So here's the good news, bad news. Medicare itself doesn't pay for the team approach, but because they don't pay for it, they also don't regulate it. So it gives persons an opportunity to develop it in many different ways and different models. So I'm just going to pause here because we're going to distinguish between palliative care and hospice care. So before I do that, I'm just going to ask you if you want to share any experience as to your own personal or family or a friend accessing palliative care. Has anybody experienced palliative care?
Hello.
Hi.
My mom did use palliative care. She was terminally ill, but she wasn't really facing that terminal illness. And then when the hospital offered palliative care, she was willing to accept that. And so I think that really helped, and it helped. I had a sister who wasn't accepting of the diagnosis either. And so having the nurse from the palliative care team really explained to her, what was happening and what would happen. It really helped so that someone else in the family didn't have to do it. So we had a really good experience. It was in Fargo. And so it was really good for our family.
Awesome. Dawn, thank you so much for sharing. It is sometimes, it's like if you're the closest to the healthcare system, the rest of your siblings depend on you to be the bearer of all this information. And it's really helpful to have somebody from the outside who maybe's had conversation with the physician, who understands diagnosis and prognosis to bring that forward. Thank you for sharing.
Yeah, you're welcome.
Anybody else?
I'm Sue Sorensen from Hospice of the Red River Valley.
Hi,
And
Sue.
Hi, and we do offer it. We have maybe for the last 4 years, but how we offer it, and it has changed many times, and we're continuing to make changes
So
with how
kind
we
of,
provide it.
okay, so kind of rediscovering how best to deliver it within what the needs are and where do the referrals come, and how can you meet those needs without a whole lot of reimbursement?
Exactly. Yep.
It would be my, yes. Thank you, Sue. Keep on
Sure.
doing it. Keep on reinventing yourself.
Thank you.
I'll just share real briefly. My father and mother 2 years ago were living at home in their own apartment. And then, the cascading events of suddenly an event happens and then they both declined rapidly. And a very long story short, my father fell, and upon that fall, fractured a lumbar disc or spine, and then involving a disc, and was hospitalized here in Rochester. And as the teams were rounding, they also found out that in all of this, part of the reason he had a fracture and fell, he had multiple myeloma. And it was probably quite advanced looking back now. And so the team was coming around and saying, oh, I think we should do a kyphoplasty. We should take some bone marrow from a cadaver and we should put in sort of the bone cement in his lumbar region. And as I was sitting here listening to that, and my father kept looking at me and saying, what should I do? And I said, well, Dad, you're not in a lot of pain. At that point, he was just taking extra strength Tylenol. And we couldn't get a solid answer as to whether this procedure would be done under general or local anesthesia. There's a big difference, isn't there, in risk? And we could not get, as they didn't really say, and we're not really sure. And somehow, somewhere, and I teach this, but I am the daughter, exhausted because I'm now caring for both of my parents. Somewhere in the recesses of my mind, I said to myself, I think we should ask for a palliative care consult. Best thing we ever did. So a nurse and a physician, it wasn't the whole team, spent about an hour and a half with my dad. Now that's unheard of when you talk about typical, rounds in a hospital setting. But they asked him about his preferences. He had been very open all his life about not extending life. Quality was more important to him. He did not want to be separated from my mother, who had dementia, because they were a team. She had the physical body and he had the brains, if you will, and the memory. So the palliative care team came in, and I wasn't able to be there at the time they visited with my father. But now, with the advent of the Epic chart, and I was a healthcare POA, I could go in and read what they wrote. And I will never forget, it just leapt off the pages at me. They did a palliative performance scale and charted it on him, stating it was about 50%. And Sue, you know what that means, 50% of a PPS. And they also wrote he may be eligible for hospice. And I'm going, you've got to be kidding me. And I'm the daughter, I'm supposed to know this stuff. And I do for everyone else, but not my dad. And so, Dawn, when you talk about, family being in different, and certainly my siblings were nowhere ready for the hospice discussion. But because of the palliative care consult, my dad did not have surgery. My dad went home with excellent pain management and enrolled in hospice because of what they wrote in the chart. I asked for a hospice referral and a consult, and my dad died 21 days later. You know, how sad. Again, all the years working in hospice and or palliative care, and we still have such late entries and late referrals. And my dad didn't believe he really needed hospice. He told me, I think you're trying to make me more sick than I am, is what he said. Then he said, but that nurse over there, that my daughter Laura, she always tells me people enroll too late, so I guess I'll sign up. But had it not been for the palliative care consult, I think it would have been even less time for him to experience hospice, because it was like peeling my eyes back to really have, like Dawn, you said, somebody objective coming in and seeing really how debilitated he already was by the time this happened. So I think most of you might know better, you know, what is hospice. But if I just look at this list here in comparison, palliative and hospice both provide comfort care. It's never about not caring. What is different, though, is hospice is provided, as you know, when there is that diagnosis of a terminal prognosis. Now, where did the government come up with 6 months? I don't know. I haven't been able to find it in all these years. You know, as the hospice benefit was established in 82 and then enacted in 83. I don't know if the politicians just said, 6 months sounds like a good benchmark. I don't know, because there's nothing magic about that 6 months. No research was put into it. When is somebody terminal? Well, we know that nationally people spend around 21 to 25 days as a median in hospice care and services. Well, if we're looking at 6 months, we're far under referring, if you will, to the hospice program. So could palliative care be a bridge that would also encourage earlier referral? And the answer is absolutely yes. Palliative care can be offered the same time as curative. And hospice is really about saying, in fact, Medicare requires our patients sign their election of benefit form, which states, I understand hospice is not curative in nature, but palliative. Now, people can opt out of hospice at any time and say, you know, I found out there's some good new seaweed out in Colorado or California, and I'm going to go for it. They can opt out, as they can with palliative care. There's very limited coverage for palliative care. For example, palliative care, because it's not funded by the federal government, does not include medications. It does not include rental of equipment, if you will. It doesn't include all the services that is provided through hospice. Palliative care funding may cover the nurse practitioner, the physician, and the physician's assistant. And there may be some limited visits by a palliative care team. Medicare only looks at covering the physician, the PA, or the NP if they code it correctly. And remember, all physician visits are covered under Part B at 80%. So there's still a copay, where in hospice, it is under the Medicare hospital benefit, covered therefore at 100%. With either program, I have never, to my knowledge, heard somebody say, wow, that was way too much support, way too quick, way too early. The comments I hear is, oh, I wish I would have had this support earlier. You know, I really wish that we would have known about it or heard about it, etc. So palliative care programs, I've just mentioned this, there's no coverage, unfortunately, for many of the treatments and the therapies beyond the typical insurance coverage. And there is a palliative care directory found at this link at the MNHPC, the Minnesota Network for Hospice and Palliative Care. If you decide you want to find out in your 22 counties, Amy, who has sort of raised their hands to say, I provide palliative care. So I got ahead of my questions there, but now we'll go into hospice care. And I've had people also say, how do we even, if we go back to this, how do you pronounce this word? And I don't know what your role is, Sue, with Hospice of the Red River Valley, but as the founder of our program, I would have people call and say, how do I get into that hospice? where do I go? Where do I bring mother? Um, and sometimes confusing it with a hospital or respite care or a spice, maybe when they call it hospice. But I always knew they were calling for a reason. And so therefore we need to dig into that conversation to ask, why did you call and how can we help? So when people talk about hospice, they often talk about hospice, and then they talk about people, and then they talk about the service, and then they talk about the philosophy. And so I would just like to say there are 3 different parts to hospice. The philosophy is to provide care when cure is no longer achievable or attainable, short of a miracle. But it also then is beyond the philosophy because it involves a team, and then that team renders services, if you will, and they all focus around the patient and the family. It is the only Medicare program that requires we enroll the patient and the family as whomever that person determines to be their family. All of our other Medicare programs are all about the patient only. So it's exciting that way back in 1985, they said, you know what? We realize somebody who's terminally ill needs more than that. And of course, I love Charlie Brown, who says, we only live once, Snoopy. Snoopy says, wrong. We only die once. We live every day. I bring that up to just mention to you, I was speaking in New York one time and I asked the audience, how do you describe the difference between palliative and hospice? And somebody in the audience said, well, hospice is for care of the dying and palliative is for the living. And I said, well, sign me up. No, the point being, hospice is for care of the living until they die, right? One isn't a death program and one's a living program. They are both similar and different in their offerings and their services. Hospice, and there is another phonetic pronunciation, is a special kind of care that, as many of you know, the history goes way back to Cicely Saunders, Yale University, Florence Wall. Those are all names in our history as to those individuals who said, you know, caring for persons at end of life isn't just about a nurse. And I love to go back and read Cicely Saunders. You know, she had a patient called David, who she spent so much time trying to manage his physical pain. And it was because of him. And often it is because the people in our circle, and Sue, you say we keep trying to redefine what it is palliative care. It's because often the people within the programs and the needs help define what it is that we're going to do for them, isn't it? We have to figure out a way. You know, we can't just run to I heard a politician this morning, you say something on TV and I thought, I'm going to repeat this. I like it. He said, the cowards run to the corners when there's a problem. The persons who want to face a challenge stand in the middle and try to figure it out. Don't you like that? I just think that's a really good analogy. So hospice is about providing care, as I said, for the patient and for the family. So if we look at the philosophy, it recognizes that quality of life should be encouraged. Well, that is a big peanut to peel or crack, isn't it? What is quality of life? I cannot define it for you, Amy. It is whatever you define as your quality of life. What brings meaning? What brings purpose? And it changes as we go through different seasons of our own life, doesn't it? You know, my quality of life isn't starting a brand new job right now. My quality of life is being able to figure out how I maybe step out of working so much so that I can spend the time. I do the simple math. What do I want to do for the next 10 years, 20 years, 30 years? What does that look like? Hospice care also, we try to say, how do we, during this undignified season of life, any hospice nurses, social workers, therapists on the line, what is dignity when I'm having to have my son wipe my bottom at end of life or hold my emesis basin? That is tough, isn't it? I worried about that with my father. And then my mother died 11 weeks after my dad of a broken heart. It was a hard year. I often worried about how I would care for my parents, who had led a very private life. But as my father specifically became much more ill, we just kind of breezed into that part of it because he didn't have any other choice. It was just, we're just going to do it. And I'm going to be his daughter and try to be professional. But he kept saying, Loris, the most important thing for me is I want to get to the bathroom by myself. I don't want these young gals in this assisted living to have to help me to the bathroom. That was about dignity and privacy for him. And so we had to figure out some ways in which he couldn't get to the bathroom by himself. You know, and where's the commode and where's the urinal and what can we do to allow him as much privacy and dignity? And it often was a conversation, to be very honest. Another part of a conversation for him was he was suffering, not pain-wise, but financially. He continued to worry. Do I have enough money? Will I have enough money to stay here? Do I need to move somewhere else? And he had saved, he was so frugal. But one of his great concerns was, am I going to outlive my money? And then what does that look like? And so what hospice did, and the social workers come along beside him and gave him space to talk about that and to acknowledge it. He didn't want to worry the rest of us kids about it. We also want all of our hospice patients to be offered the options that are reasonable. You know, some of you have read the book Being Mortal by Dr. Atul Gawande. And talking about, you know, we used to be, our medicine used to be, oh, there, you've got it. Okay, good. I love it. Bookmark that and read it. And there are other, Ira Byock and others that are just excellent. But he often talks about, I've heard him in person, he said, back in the Marcus Welby days, as our parents were raised, the doctor knows everything, right? And then Dr. Google came along. And we can Google anything and we can kind of find the answer that we want about anything, regardless of it not being a reference page. And he said, what we need to do in medicine is bring those two together. And when our patients and families ask us, such as in palliative care, what are my options? You know, a diabetic, you instruct them to shop the outside of a grocery store, not the inside aisles that are filled with all the processed foods. You want them to have fruits and vegetables. And so he said, we don't have to give every option to a patient of everything that we know retrospectively is not going to be beneficial to them. They're seeking this good guidance, and that's what we need to be doing. What is most important to our patient? When we say live life to the fullest, well, what does that mean in their world and their perception? And so part of what I know I as a nurse have done is make it my priority to be sure that people physically are relieved from the level of pain. And again, assess what is it they would define as relief, so they can get on with some of the emotional and the spiritual suffering and dealing with that as needed. So I'll kind of fly through this. I've already mentioned that hospice is for those folks that are terminally ill with a life expectancy of 6 months or less. And we know that physicians overestimate, and we don't kick people out of the program based on, oh, they live 6 months and 1 day, so now we're going to discharge them. And you all know this on the phone, but part of the reason I'm even emphasizing it is that we did a fair number of listening sessions as I traveled around with the Minnesota Network of Hospice and Palliative Care, and we found there are still myths out there. Well, this is only for 6 months. What if I live longer than 6 months? Will I be kicked off? Or hospice is really expensive. Or I have to be do not resuscitate to be in hospice. That's a myth. We cannot require that as hospice providers. So steps to admission. A referral can be made by anyone. then the hospice team evaluates eligibility because we have guidelines we need to look at to access the Medicare benefit or the medical assistance benefit if that person is under 65. But it is the patient or their representative who elects this benefit. It really is a financial transaction because they're choosing to put their Medicare Part A hospital insurance in the back part of their wallet. And now the hospice benefit is in the front of their wallet. It becomes, if you will, and this might be an overstatement, a managed care program. And that's why we tell the hospice patient, please call us first before you call the ambulance, before you go to the hospital. Not that we want that much control, but we want to be sure that you're not burdened with financial bills that you wouldn't have to pay had you gone through hospice. The patient can revoke at any time. I mentioned that. And also, have you heard of hospice patients being discharged? We call it kind of, for lack of any better word, graduation. My mother-in-law was in hospice. She was discharged because she stabilized and in fact improved. Her medications were adjusted. There was some deprescription of medications. There were some other things that happened. And they basically said, you know what, Jean, you are healthier than the day you were admitted. So we are going to need to discharge you, but we'll be here for you again. And then we have recertification. So we're talking about now, if you looked at those components, we looked at the philosophy, we looked at who is going to, the eligibility, and then let's look at who is going to provide the services. Those services are provided in the person's home. And this can get a little confusing. So could that be on the streets in Hawaii for a homeless individual? The answer is yes. Could it be in a nursing home where that person lives, or assisted living, or adult foster care? What about jail? Yes, yes, yes to all of those questions, wherever that person calls home. And obviously there's a lot of things that the hospice agency looks at the enrollment. You know, is this a safe place for the individual to receive services? So the levels of care, there are 4 levels of care. And when I'm talking about this, I'm talking about Medicare, but fortunately in Minnesota, North Dakota, the same levels of care are mirrored with our medical assistance or Medicaid programs. Most of our persons are in their home because that's where they desire to stay. Maybe not jail so much, but if they're in a nursing home, that's where they would desire to stay, etc. So that's where most of the care is rendered. Medicare also pays for up to 5 days in a Medicare certified facility for relief of the caregiver. That is not relief of paid caregivers like assisted living or the nursing home. This would be for family caregivers. We also have something called general inpatient. So if you think about this as managed care, once the hospice patient enrolls in the benefit, the goal is that the hospice team follows that person, regardless of the complexity or the severity of their illness. So general inpatient might be for the individual who develops pain that's out of control. Sue's been out to the home. I keep picking on you, Sue, because you self-disclosed who you are. And she's sitting in her car and I want to be sure she's not driving. So I'm picking on her while we're talking here. But it might be that Sue has been out to the home as the nurse frequently and just cannot get on top of Dawn's pain. And so we need to have a place per contract for the individual to go so that we can get on top of their pain or bowel obstruction or their hip fracture or whatever it might be, because we just can't do it in the home, the place they call home. Continuous care is something that's not often utilized because we have trouble finding staff. But that would be if we're frequently seeing that person under nursing or home health aid in the client's home during periods of crisis, because we're trying to keep them there and we're providing more than 8 hours and 24 hours. Medications and treatments related to the conditions of their terminal illness and comorbidities. So I might suggest that when somebody's in hospice, hospice is picking up almost every medication, maybe excluding atropine eye drops for glaucoma or thyroid medication. That's not a terminal illness, but almost everything else, COPD and CHF, et cetera, because the comorbidities add to that terminal illness, if you will, or prognosis. We also in hospice would cover radiation chemotherapy if it was for palliative measures, blood transfusions. So for example, I think of John McCain. If you remember, he had an astro or glioblastoma, a brain tumor. So somebody that has been on medication perhaps, but they still complain of a terrific headache. And maybe 5 doses of radiation specific laser therapy to that area may decrease, if you will, the swelling, therefore the symptoms of the headache or seizures or what might you have. It is not that we're providing it under hospice for cure, but it's simply for interventions to palliate. Medications, if you want to know how expensive medications are, you can download an app that's called GoodRx. Have you heard of it? And you can even check per your zip code what your local retail pharmacies might charge for a medication. So just put in there fentanyl patches and oxycodone and morphine and lorazepam sometime, just to find out what kind of expenses the client may incur. And to have that paid for by hospice is sometimes the reason people sign up, because I know you're going to pay for it. Medical supplies shouldn't be anything that's too surprising here. But for a hospice, we don't ask the client to go in for all kinds of lab work, arterial blood gases to find out if they qualify for oxygen. If they say they're short of breath, we might start a fan to blow air around in the room. If they're still short of breath, then we would look to perhaps renting oxygen. So emergency transportation covered by hospice if approved by hospice. Short-term dialysis, blood transfusions, again, specific in nature, dependent upon our conversations of preferences. So the team, for sake of time, I won't go through all of these, but I've already mentioned all of these team persons available around the patient and their family. So I think I know personal experience. It was awesome to have access to these team members that are listed here. Some of you might say, hospice and therapy? Really? Yes, I call it therapy light, because a physical therapist might give us just the thing we need to circumvent or to treat the contractures a patient has, or to measure for the best fitting size of a wheelchair, or guidance in where to put rails in the bathroom, et cetera. Occupational therapy to deal with perhaps some really good tips. They can provide us good tips on energy conservation for both the patient and family. Maybe it's a one-time visit, but let's not forget about our therapist. And then we have all of other integrative therapies. By the way, none of these are covered by Medicare. So that's why hospice programs raise dollars, or they have gifts, donations, grants. None of those are paid for by Medicare. And the family is integral for hospice at home, in a home setting, in a residence. Who is the family if the resident is in a nursing home? Well, it's their family, but we also involve the other caregivers as part of who it is that we teach and integrate and collaborate with. This might just give you a bit of an idea. Medicare, I already mentioned to you, and medical assistance reimburse at 100%. Most health plans have now followed suit. I am so old, I remember the day back in the early 90s, Blue Cross Blue Shield did not pay for hospice. Can you believe it? They did not. So we've come a long way. Now we just need them to step over the line and pay for better palliative care as well. Hospice does not pay for the room and board in a nursing home. Sometimes people are confused with that because the Medicare skilled benefit for a nursing home does. Hospice does not, nor do we pick up the mortgage or the rent for people. And that's why I would just say it doesn't, the hospice services and the reimbursement from Medicare does not change as to whether that person lives in their own home setting or is in a nursing home. So we have to have those discussions. Who's going to pay for the room and the board charges? And we work together with our contracted nursing homes. Assisted living in Minnesota, and I think in North Dakota, does not have a specific contract with hospice. Sue would know that better than I do. In Minnesota, it's not required because there isn't any money exchange like there is with hospice and with the nursing home. The nursing home sends hospice the bill as a pass-through. But we collaborate. And in Minnesota, there are over 66,000 persons living in assisted living today, 33,000 in nursing homes. So by far, there are more persons living within assisted living than nursing homes. Here's just a couple little facts that I thought might be helpful for you. Let's talk about hospice for the last months of life, not the last days of life. We need to change our verbiage as healthcare professionals. Hospice doesn't require the patient to give up their physician. Some people think, I've got to give up my doc. Oh my goodness, no, hang on to them. And we don't say, and these are myths I've heard through my years. Well, if I'm admitted to hospice, I can never go to the hospital. That's very untrue. You might need the hospital. We're going to try to forego it, but you have a broken hip, you have something that requires that acute care stay. Of course, you would have access to a hospice. So here's another link for you again, if you want to know some hospice providers, happen to be specific to Minnesota. And people have a choice. I do know that some of our large systems have what they call the web or the keepage. You know, if you're in XYZ hospital, then this is the hospice program you're going to get. That isn't required. And people still have choices. I think sometimes they're not given the choices we would expect. So I'm going to open it up because Amy, that hour has gone faster than fast. And we started at 12:03. It's now 12:02. So does anybody have any questions for me? Or was there anything typed in the chat, Amy, that I should know about?
I did not see anything come through the chat, but certainly if you have a question, you can unmute and ask the question directly. Go ahead, Deb.
Can a nurse practitioner make a referral to hospice or palliative care?
Absolutely. Absolutely. Even a family can. A
Okay.
family can say, I want to know more about, like I did with my dad. I wasn't functioning as a nurse. I was functioning as a daughter.
Mhm.
And I said, can we have a palliative care consult? And Dad's doctor wrote the order. So therefore they then came. Anybody can make a referral. Absolutely, Deb.
Okay, great.
Good
Great.
question. Good question. Anybody else with a question or comment?
Well, I have a comment. This was great information. I love how it was presented. It really, I mean, even though I knew the difference, there were a lot of things that I learned today that will help me as I'm even explaining it to other people or talking about it to other, including my own family. So I really appreciate the information.
Thank you, Sue.
Good. And I'm gonna make sure that, just so everybody knows this, I did record this. So I will send this out. And then also I will send out the PowerPoint that Laura sent to me. And then she had another handout with it. So I'll send those both out. So, and you know, if some of you have to drop off, that's fine. But if some of you have questions and you want to stay on just for a minute, but I do remind you, go to the Dancing Sky Facebook page. We have lots of webinars that we do education, and they're all advertised on there, and we'd love you to join more of these webinars.
Amy, thank you so much for that. I called you Sue a little bit. I was looking at my little box to see which Brady Bunch kid was talking. But also one of the handouts that that Amy will send to you was developed by the National Hospice and Palliative Care Organization, clearly defining palliative and hospice care. So feel free to reproduce this if it's helpful when you have discussions with your family. It's a 2-pager. So thank you. Thank you, Amy. Anybody else? I'm willing to stay on for a few minutes or whatever Amy wants. Yes.
My name is Tammy, actually. My last
Tammy.
name is Freed.
Yes.
I am a volunteer with Lutheran Social Services in their respite care
Yes.
program. So this has been good and informative for the clients that I see. I'm still a little, is there just a little, if someone, I'm still a little unclear about the difference between the two.
Yes.
Is there one kind of thing that kind of separates?
You know, here's one way I would explain it to you. Perhaps if you look at palliative care, you see my hands up here. I talk with my hands.
Mhm.
It is like a huge umbrella. Hospice is one part of, if you will, the rung of that umbrella. Because hospice is defined as services at end of life when somebody's terminally ill, whereas palliative can be for any age, any time, any diagnosis. Can be for our little kiddos that are in the NIC ICU, who the family is saying, help me. Should we send our little one for yet another surgery that might be life limiting or high risk? Bring in this palliative care team that can help me sort through what I'm hearing and the complexities. And I'm in the emotional stages of trying to even, I don't even hear half of what you say. So palliative is really this overarching, larger umbrella, if you will, that doesn't have the defining treatment versus not treatment, end of life versus not. It's just much, much broader than that. Focusing again on preferences and what matters most to that person and to their family. Does that help at all?
Yeah, I'm just not as familiar with the palliative, I can't even say it yet.
I know.
Hospice, both of my parents went through hospice, and that was wonderful. But now this fall, my father-in-law, that's when I first heard the palliative.
Yes.
But unfortunately, complications with hip surgery and infection, I first heard about the palliative care, and I think that's where they started talking about, we're not going to do any more surgeries. We're just going to keep you comfortable or that. But he was only really in that for about a day and then went to hospice and was only in hospice for a couple days.
Yes, yes.
So it all kind of jumbled together in his situation.
Yeah, yes. And palliative care is vague. It feels gray. It feels mushy. That's a good clinical term, isn't it?
Yeah.
It kind of feels mushy. I think during this day of COVID-19, there has been a little bit more, if you will, emphasis. Diane Meyer, who is a leader in palliative care, she said they did, and I have many different scripts in which they came to persons, for example, living in a nursing home and saying, if you were to acquire COVID-19, what are your wishes? Do you want to go to the hospital? Do you want to stay here? So it's kind of, it's all wrapped up to say, well, for heaven's sakes, instead of just calling 911 every time we think we should, maybe we should hit the pause button and ask Sue or Deborah, tell me again, what brings you value? What would bring your preferences? What are your preferences?
Mm-hmm.
And so, like my little example about my dad, he was facing potentially some major surgery. And we just wanted to hit the pause button to say, for what? Does that meet with what he would want? And what is the risk of general anesthesia for somebody who is 90 with multiple myeloma?
Right.
And I think for him, one of the values, somebody just stopped and at least asked. And a palliative care consult, I don't know how it is in your area here, and you have to have administrative support to do all of these kinds of programs, but the team came in and spent a good hour with my dad, listening to him, getting to know him. When do we do that in healthcare? We don't most of the time, unless you have some exceptional. And And also in a hospital setting, when the stress is so high, and most of the time the physicians seeing individuals in the hospital are not the primary physician. So if that helps a little bit, I could talk on and on about palliative care, but it is, and my suggestion would be, if you feel that you have a patient, a client that might benefit from it, each palliative care program is different. And so you might say, what do you offer? If I make this referral, what does that mean here in this community of Detroit Lakes? Because again, Medicare is not typically paying for it as a big benefit. And so it might be run and structured differently. Any other questions? It's really, thank you for being brave to ask.
Yeah. Amy, maybe you can answer this. Are there specific, I'm in Otter Tail County. Is there specific, I know the hospice facilities are the ones that offer hospice. Are there any specific palliative care programs that you're aware of?
I would say, like Laura's mentioned, is that often it's through a hospital system.
Oh.
But each individual hospital system you should check with, but also the hospice organizations themselves often now offer palliative care. So again, that would be talking with those individual hospice organizations. And as Sue mentioned, Hospice of the Red River Valley is one of them that does offer palliative care.
Yeah, and that's based in Detroit Lakes?
Well, actually, I believe your official base, Sue, is Fargo, but there's a office in Detroit Lakes.
Okay,
And we provide service to all of Otter Tail County.
that's what I thought. Okay,
Yep.
good.
And feel free to.
But a good place to go to is the senior linkage line. That is one of our services as well. Dancing Sky and all of the area agencies on aging in the state offer the senior linkage line. And so that's a place to call and get connected with different services. So that would be a great place to start as well if you're confused about where to go, or even just
Excellent.
contacting those like I said, hospice organizations, those hospitals directly, and asking that question.
Okay, good. It's just always helpful to have resources available
Absolutely.
as a volunteer out there. And Lutheran Social Services has resources obviously as well, so.
So I will just, I don't want to keep you, but I think this is sort of humorous, but also revealing. Do you remember years ago, fathers of mothers that were in labor and delivery were not allowed in the delivery room? Now they are. Do you know how that happened? I'm not sure if it was the mothers or the fathers said, let us in. So it's out of the demand. So I think the same thing with palliative care. If we start saying, we want different kinds of care, we want to know our options, we want to be supported in what those options are and fully informed, I think more palliative care programs will come about. And you know what? Now this is on Loris's stump. Why do we need a special program to do what we should be doing already? Would you agree?
Yeah.
Really, it's the right thing to do. But form often follows funding, and that's can be some of the deterrent. And I see Sue has already put down in the chat, feel free to contact me. She's got her phone number. So that's awesome. Awesome. Well, I want to thank you, Amy. Reach out to me, Amy, if there's anything I can do or to further clarify the conversation of today. But I'm so excited. I got to be like in your midst from way down here in Rochester. Thank you.
Well, thank you very much. We appreciate the information. It was wonderful. And like I said, these resources, I've looked at these resources, and I think the 2-pager, especially that you mentioned, Loris, will kind of answer some of the questions that you might have as well, and give you that good resource to have on hand. So I appreciate it.
Great.
And we're getting some comments. Thank you. Very informative. It's been helpful. So
Good.
thank
Good.
you.
We can't boil the ocean, but we can influence our little surroundings, can't we?
Mhm.
That's what I keep
Absolutely.
saying. Don't get discouraged. So Thank you, everybody. Happy Thanksgiving.
Yeah,
Thank you.
thank you. It was great.